So I am happy to have with us today Lindsay Daw. She's the Division Manager for Medicine in Carbonear General Hospital. Lindsay has been employed with Eastern Health since 2006. In 2007, she graduated from the Center for Nursing Studies with a Bachelor of Nursing degree and completed her Master's of Nursing degree from Memorial University in 2021. The majority of her career has been spent working at Carbonear General Hospital, primarily in surgery and obstetrics. In 2019, she began a new position as a site clinical manager, responsible for the rural Avalon, including the Carbonear General Hospital, the PJSMP, AAW, New Hook, Lions Manor, and PHC. Most recently, she has taken on the role of the interim division manager of the regional medicine program at Carbonear Hospital. So it is with great pleasure that I'll give the presentation portion over to Lindsay.
Thanks, Peggy. So this webinar is actually a condensed version of my practicum project, which I completed as part of my master's program. So basically, I completed a lit review, which determined that the identification and management of clinical deterioration is problematic among novice nurses. So following the lit review, I completed consultations with key stakeholders and nurses working on the surgical unit here at Carbonear Hospital, followed by an environmental scan to determine available resources within Eastern Health. So the goal of this webinar is to help novice nurses identify and manage the deteriorating patient. This is a very important topic for nursing education. Providing education to nurses on the identification and management of clinical deterioration is important for nurses because it has a positive impact on the delivery of quality patient care. To provide quality care, it is important that nurses have the assessment skills to detect when a patient's condition is deteriorating. Nurses' ability to recognize and respond to signs of patient deterioration in a timely manner plays a crucial role in patient outcomes. Early detection of clinical deterioration has been shown to reduce ICU admissions, cardiac arrest, death, sepsis, and other acute clinical conditions. When clinical deterioration is not recognized promptly, there is an increase in patient morbidity and mortality. So just a brief rundown now of what the next hour will entail. So I'll provide a brief introduction, followed by some background information, which includes significance of the problem, issues identified in the literature, issues identified through the consultations and environmental scan. There's a brief video and an opportunity for some reflection. Physiological changes associated with the deteriorating patient. And then if time allows at the end, there are some case studies. The case studies were strategically placed at the end for the half-day workshop, which I developed. So we can just kind of go through it briefly as a group if time allows at the end. So learning objectives, number one, identify 3 key factors negatively impacting the nurse's ability to identify and manage the deteriorating patient. To demonstrate effective communication skills to manage the deteriorating patient, and to formulate a plan of action to identify and manage a deteriorating patient. So brief overview, 1 in 10 Canadians are harmed in acute and home care settings annually. Following a review of the literature and consultations with nurses and key stakeholders, there has been an identified need to educate nurses on the identification and management of clinical deterioration. Nurses have an ethical and legal obligation to provide quality nursing care to promote positive patient outcomes. Therefore, it is essential for them to be equipped with the knowledge to determine when their patient is declining. Today's session will help you become more familiar with the significance of the issue, contributing factors which cause nurses to have difficulty identifying and managing clinical deterioration, discussions on some personal experiences with declining patients, and case studies to integrate all the information that you have learned. So what is clinical deterioration? Clinical deterioration is characterized by a period of clinical instability, which, if prompt appropriate action is not taken, may lead to increased hospital stay, cardiac arrest, admission to the ICU, and increased morbidity and mortality. So patient safety is an essential and vital component of quality nursing care. It's defined as the absence of preventable harm to a patient during the process of healthcare and the reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. And that came from the World Health Organization. Nurses have a professional and legal obligation to provide safe, competent care to their patients. Therefore, nurses must be able to identify the patient at risk of clinical deterioration in a timely manner. And top-rated health risks in Canadian healthcare. So HIRAC, which is the Health Insurance Reciprocal of Canada, is a healthcare safety advisor and offers insurance to healthcare organizations. So as you can see from the chart right here, failure to appreciate status changes and deterioration is actually rated as number 2. So it's the second highest legal risk in Canada, which is, when you look at the list of things around the chart, it is quite, it's up there, number 2, so it's quite significant. So pause and think. Just like to throw out a few questions there for you to kind of reflect on your own practice. Have you ever had a patient who was declining? How did you identify clinical deterioration? And how did you manage the situation? So would anybody like to make a comment on any of those questions? So one thing that, okay, sorry, go ahead.
Lindsay?
Yes?
Hi, this is Lisa Snilk.
Hey.
Hi. So you're asking for answers to those questions, or you just want us to reflect on those?
Yeah, so anything that you'd like to share from your own practice, like for example, like how you may have handled declining patient. Have you ever been in a situation where you were working with a novice nurse who may not have picked up on signs of deterioration? How you've managed situations in which you had a declining patient?
Well, I worked in ICU, so my background is critical care, and I do have some emergency background as well. And so, yeah, I have a lot of experience with patients that have declined. It's just the clinical skills that you develop over time, I would offer to say, especially in, observing vital signs. And with regards to, helping novice nurses, it's just assisting them in identifying those sorts of things as well, in identifying a deteriorating patient.
Yeah, absolutely. Yeah, it's really important for novice nurses to have someone experienced to be able to call on, and for an experienced nurse to relay their expertise to the novice nurses. And a lot of that came out in the literature, and we'll kind of discuss on that, build on it, I guess, as we go through as well.
Yes.
One situation that I kind of had noted, which stood out for me in my practice, was as a new nurse having a patient that had a history of anxiety, post-op patient whose heart rate went up, gave them Ativan, and it was really, really busy, didn't get the opportunity to go back and reassess in a timely manner. This particular patient actually ended up having a lot of bleeding from a post-op incision, and once the doctor was notified, some blood work was ordered, hemoglobin was low, and obviously at the end of it, the tachycardia was attributed to the bleeding and not the anxiety. So it's just little things like that this novice nurse might not have had a skill to do that full head to toe assessment to see if there was something else aside from the anxiety that may have been contributing to the tachycardia.
Oh, you were looking for like specific examples, were you?
Yeah, but no, that's fine. Lots of opportunities I've never go through.
Well, I can think of one example there, like just listening to breath sounds, for instance. I had a patient that was deteriorating, and the novice nurse didn't pick up on it until I just listened to breath sounds, and I was able to identify early on that patient was going into congestive heart failure, and the appropriate management was initiated before the patient condition got worse. So that's just a little example there, I guess.
Yeah, awesome. All right. So significance of the problem. So globally, as many as 40% of patients are harmed in primary and outpatient healthcare settings. Up to 80% of this harm is actually preventable. The rate of harm for surgical patients is higher than that of medical patients. 20 to 30% of ICU admissions in community hospitals come from general wards, as opposed to, say, the ER or post-op recovery room. And then failure to rescue increases morbidity and mortality. And failure to rescue means that the nurse did not properly identify the deteriorating patient. So another pause and think. Research suggests that nurses have difficulty identifying the deteriorating patient. Would anybody like to comment on why they think that nurses may have difficulty identifying the deteriorating patient? Anything that you can specifically think of with regard to your, maybe like a unit that you have worked on or you are working on? So a few things that were actually found in the literature. New grads working in less acute areas have little to no exposure to acutely ill patients. There's a lot of evidence which points to inadequate nursing orientation. Also, inadequate numbers of senior or experienced nurses on some units. And then it's also been shown that there's a lack of freedom or an opportunity in clinical, specifically in nursing school clinicals. So, just going to discuss now some of the major findings from the literature review. So, literature has identified 7 themes which contribute to nurses' inability to identify and manage clinical deterioration. They're divided into 2 headings. So first is nursing factors, and then second is work-life factors. So we've got knowledge, confidence, and experience are the 3 nursing factors. So knowledge and experience. Research has shown that novice nurses often miss the signs of patient deterioration because they do not have the knowledge and experience to identify when a patient's health status is declining. Objective data through physical assessments provides key information on patient status. Nurses must have the ability to detect when something is wrong. So interpretation of abnormal lab values and vital signs. So novice nurses don't have the knowledge and experience to interpret abnormal results or the meaning of changes in vital signs. Vital signs are one of the most important signs of a change in health status. And one of the systematic reviews that were included in this literature review found that med-surg nurses often inaccurately interpreted vital signs, such as perceiving blood pressure as the first sign of deterioration. The second point here, inability to recognize subtle changes in patient status. So lack of experience causes an inability to identify subtle cues. And an example of a subtle cue could be a decrease in activity level. There was one article that I read in which there was a patient who was ambulating really well post-op, and then suddenly, like maybe post-op day 3 or 4, there was a really big decline in their mobility. So that was taken as a subtle change in status. Changes in status documented but no intervention. The novice nurses often don't have the knowledge and experience to understand what interventions are necessary when a change in status occurs. And then judgment errors. Judgment errors have been shown to cause a delay in escalation of care. And escalation of care essentially means cognitive decision. Confidence. So lack of confidence in the clinical setting may compromise the delivery of safe, competent care. So nurses lack confidence in providing patient assessments. One study in the lit review explained that novice nurses need to consult with more experienced nurses to seek guidance or reaffirmation when they feel that their patient is deteriorating because they lack the confidence in their assessment skills. And then communicating abnormal findings. So it was also found that a communication hierarchy exists on some units, and there's also a fear with novice nurses have a fear of communicating with more experienced nurses and or senior staff, physicians, or whatnot. So how can we increase confidence? We can increase confidence by increasing exposure. Would anybody like to comment? Does anybody have any experience working with novice nurses, or are there any novice nurses online that would care to comment on their level of confidence or how it's increased over the years with, more experience? Nurses who are experienced in one clinical area, this is one thing that came out in the literature as well, and also through my consultation reports. So if you're experienced in one clinical area, you may not be experienced in another. And it often takes years of experience in one area, years of experience in one area don't necessarily translate to the same experience in a new area. So, for example, like if you're a community health nurse coming into a surgical area, you might have 10 years of experience in that area, but you're still considered a novice nurse working on, say, mid-surg, for example. And it might take you a little while to develop those competencies and the same level of confidence that you had working in community. Then there's 4 work-life factors. So patient assignments. Continuity of care is needed to ensure knowing a patient's baseline. This was identified in the literature as a key theme in identifying patient deterioration. One study found that in-depth knowledge of current health status helps identify subtle changes in status even before physiological changes were recognized. Staffing levels. Reduced staffing levels at night affects continuity of care and patient safety. Increased workload affects the ability to recognize clinical deterioration. One study found that delayed escalation of care or interventions due to increased workloads occurred in 20.7 to as high as 47.1% of patients. Higher nurse-patient ratios have been found to lower the incidence of morbidity and mortality. Staffing levels, inadequate staffing levels can also lead to complex patient assignments, and an increased nurse workload was also a theme in the consultation reports as well. Inadequate communication. So poor communication between healthcare providers can have a negative impact on patient care. And communication issues between nurses, for example, during handover report, and between physicians. And as I just mentioned, the communication hierarchy that does exist on some units. One mixed methods study revealed that some units have an established communication hierarchy in which the RN is actually excluded from decision making. That was really surprising to me when I read that, actually. There's a fear of being criticized and a sense of intimidation with novice nurses. And communication failures were one of the themes in the consultation reports as well. Unit cultures. So several things related to unit cultures, which came out in the literature, were things like leaving lab work until night shift, omitting respiratory rates, leaving lab results to the physician to assess. And one study found that nursing assessments were often not completed at night because nurses do not want to wake patients, for example, those that are at risk of delirium. They're leaving those patients, they're not waking up for nightly assessments. Or if you have a certain patient, maybe you had a patient that didn't sleep well the night before, and so you just, they're sleeping well tonight, I'm not going to wake that patient up at 2 o'clock to check their vitals or do whatever assessment that's necessary. So a consultation report and environmental scan. The biggest theme that came out here was that there's an inadequate orientation. So why? So I'd like to ask you guys if there's any, if you guys have any comments on why there's a lack of proper orientation or adequate orientation on any of the units that you guys have worked on. One thing I'd like to comment on, this came in big in my consultation report, which was completed here in the surgical unit. And for anyone that's familiar with Carpenter Hospital, the surgery unit is a unit which has labor and delivery and obstetrics and gynae as well. So, there's quite a diverse population. But related to the case room and the way that the unit is laid out and staffed, inadequate orientation often happens on this unit because lots of times the staff are taken from the surgical unit to go into the case room if there's a laboring patient, which gets problematic when you have a surgery nurse that's actually doing orientation with a new nurse to the unit. And then there's staffing shortages, and I mean, we can all, I'm sure we all have experiences that we could share when it comes to staffing shortages. But related to that, sometimes it's problematic to do a proper orientation when there's staffing shortages because you're not getting the same preceptor, and then there's a lot of staff coming and going. This particular unit, there's a lot of nursing staff which are new, like within the last couple of years. So we've got new nurses orientating new nurses, so that can get problematic as well. So then, yep.
This is Melanie. Great job so far. I know when I was doing orientation, as you know, I'm float nurse at Carpenter Hospital. When I was doing my orientation on the surgery floor, I found I was being hauled back to medicine because of short staffing issues. And so I wasn't getting a good orientation on the surgery unit. And not that I'm down there that often, but sometimes I still feel a bit uncomfortable down there just because I didn't have the full orientation down there that I probably should have had.
Yeah, absolutely. Yeah, and it, like you said, it all boils back to the fact that there's a staffing crisis.
Yeah, absolutely.
Yeah, and it certainly is applicable here when we're talking about novice nurses' ability to feel comfortable, competent, and confident working on a particular unit for sure. So then, in addition to that, the environmental scan revealed that there are actually limited resources within Eastern Health which support and guide novice nurses in the identification and management of clinical deterioration. So next, I want to show a short video. This is a really interesting video that I found online, and it emphasizes the importance of open communication between healthcare providers. So Vance is a young man who passed away, and the following is a video on his mom kind of explaining her experience. That's a really, really good video, guys, to go back and watch. It really sums up the mom's frustrations with her conversations with the nursing staff and the physicians. And she's actually a nurse herself. And she was trying to relay all of her concerns to the healthcare professionals. Nobody was listening to her. He was in an accident, was found hours later, hospitalized for weeks, and eventually passed away. Really, really unfortunate story. So, like I said, it's worth your while to actually go back and listen to that mom tell the story about her son and her experience. So, anyone care to share any thoughts on what are the first signs that indicate a patient is deteriorating? So the literature has stated that the first sign of clinical deterioration is a change in vital signs. So kind of going to go back to the basics a little bit here now. Sometimes it's really important. So it is really important that an accurate vital sign assessment and documentation occurs, and that the necessary interventions are taken to correct a change in vital signs. It's a little comic. Hope you don't mind. I'm training a brand new assistant. I've asked her to check your blood pressure. Blood pressure cup is right. So physiological changes. So as I said, the literature states that a change in vital signs is one of the main indicators of a change in patient status. So blood pressure, pulse, respiratory rate, temperature, and oxygen saturation. Had this been like a face-to-face session, I would have handed out the post-op monitoring policy. But we don't need to get into that. That's something that if anybody feels they need to review, they certainly do it on their own. Documentation of vital signs is extremely important. The literature shows that nurses often increase the frequency of vital signs when there are abnormal results, but it's actually not documented. The new score, which will be discussed a little bit later, states that when there are abnormal vital signs, nurses must increase the frequency of assessment to hourly. Recognizing changes in vital signs allows early detection of complications and timely interventions that can prevent further patient decline. And novice nurses often do not recognize the connection between altered vital signs and a change in status. So normal blood pressure, 120 over 80, respiratory rate, 18 to 20, pulse 60 to 100 for an adult. So just kind of going to go into each one individually. So post-op patients often experience hypotension. Why? Number one, hypovolemia. This often occurs when there isn't enough blood volume in the body. One of the most common causes is hemorrhage, where blood spills out of the veins. When there's hypovolemic shock, the blood pressure drops, the pulse rate goes up, and urine output decreases. Cardiogenic shock. This happens when the heart can contract and pump blood effectively. Cardiogenic shock is usually caused by an MI. Sepsis, so when the body is overwhelmed by an infection, the arteries dilate and there isn't enough blood to keep up the strong blood pressure. As a result, blood pressure drops, sometimes dramatically, and the patient will also have a fever and a fast heart rate. And anesthesia and drugs, which usually happens due to a blockade of the sympathetic nervous system, causing arterial and venous vasodilation and subsequent functional hypovolemia. Pulse. So post-op patients often experience tachycardia. Why? One, anemia. So anemia is the heart's way of compensating for a lack of red blood cells. Fever, which sweating during fever causes fluid loss. Hyper and hypotension. Blood pressure changes can cause changes in the electrical functioning of the heart. imbalance of electrolytes. So certain electrolytes affect the electrical functioning of the heart, potassium, for example. And stimulant drugs. So stimulants increase the activity of dopamine and norepinephrine. Pulse. What are common causes of bradycardia in the post-op patient? So there were two that were mentioned in the literature. Number one, obstructive sleep apnea, because the body does not get enough oxygen. And then number two, medications. So some medications given during surgery may slow the heart rate. And causes of tachypnea, blood clots in the artery of the lung, COPD, heart failure, pneumonia, and anxiety. And then causes of arrhythmia are narcotics. Temperature. So what are the common causes of post-op fever? So here we have the 5 W's. Wind, so atelectasis, pneumonia, aspiration. Water, such as UTI. Wound, so surgical site infections. Walking, DVT, or pulmonary embolism. And wonder drugs, transfusion reactions, and drug-induced fever. So the big takeaway here is essentially to know your patient. That was the big takeaway that I took after doing my lit review. It's really, really important to know your patient. It's important to know their normal and what their baseline is. What's normal for me might not be what's normal for you. When monitoring a post-op patient, it's important to know their history, their baseline vital signs, and any intraoperative complications. So really important to get a good report. And then one example, so the normal oxygen saturation for a person with COPD, for example, is 88 to 92%. That would actually be considered considerably low for a healthy person. And also patients who are extremely active, like a runner, for example, may have a normally low resting heart rate. So important to know your patient and what their baseline is. I'm sure by now everybody is familiar with the NEW score. So when I developed this presentation last year, this was just being implemented here in Carbonear. It had been implemented, I think, prior to that in Buren, if I'm not mistaken. So it was implemented in 2021 on the Med-Surg unit. It's a standardized assessment of acute illness. Total score helps support clinical decision-making, facilitate the timely response, and the 6 parameters that are assessed are pulse, temperature, respiration, blood pressure, oxygen sat, and level of consciousness. So that's the basically all the material that I wanted to share. So right now, I said at the beginning that if we had time, we do a case study. So here they are. If you guys just want to take a minute, you can read down through the case study on your own. And then there's 3 of them there. Each one is followed by just a couple of really quick questions. And we can have a discussion if you want to share. If not, I can just go down through the answers that I have here. I'll give you a few minutes there to read through that. So, 3 questions. So what assessment data is important to indicate what is happening to Mrs. Jones? Anyone care to comment? So low blood pressure and blood drainage may indicate internal bleeding. Number 2, what should Janet do to determine accuracy of vital signs? So I would suggest checking with a manual blood pressure cuff and ensure that the blood pressure cuff and SAC probe are not on the same side. And should the nurses notify the physician? If so, what should they include in the conversation? So the physician should be notified, altered vital signs and saturated dressing should be communicated. Also important to note in this particular situation that the change in vital signs was greater than 20%, questioning whether the patient should have been discharged to the ward. What would you do about the dressing? Apply pressure dressing. And what might the physician order? He may order a bolus of fluids to increase blood pressure. So number 2. Should Melissa have taken any intervention following her morning assessment? So I say yes, the physician should have been notified of the cloudy urine. Were there any subtle changes in Catherine's status that warrant action? Yes, a decrease in her activity level certainly should have warranted action in this case. And are there any assessment findings that Melissa should review from previous shifts that could indicate something is wrong? So here we checking in previous vital signs, the color of her urine, her activity level from previous shifts, and the status of her wound. And the final case study. Okay, so what was the main cause of error in this scenario? So not receiving a full and accurate report led to her not knowing his history. What important detail did Tanya leave out of her report? Significant here was the fact that he had a history of COPD. And if Becky had realized Tanya had COPD, would her intervention have changed? Yes, because she would have known that increasing the level of oxygen he was receiving could cause an imbalance of oxygen and carbon dioxide.